human anatomy is very variable, and it's always quite surprising to see what you think was one thing is another, and you can confirm for sure under ultrasound guidance. So why use ultrasound in orthopedics? Hello. So I wanted to share with you some things that I've been working on and have been helpful for my residents and my fellows. So I thought I would share this here today, some ultrasound fundamentals. So as you know, I'm a board certified, fellowship trained sports medicine orthopedic surgeon and regenerative medicine ultrasound expert. And I do a lot of training and educating in orthobiologics and ultrasound. And I'm passionate about helping other physicians. So let's delve in. So why use ultrasound in orthopedics? Two reasons. One is for diagnosis. It's safe, it's non-invasive, there's no radiation, and you can use it at point of care in real time with a dynamic exam. So you can watch things moving in real time. Additionally, for MSK injections, you are quite a bit more accurate than blind injections. Even in intra-articular knee injections, it's 89% accuracy versus 98% accuracy. And you can pinpoint the pathology with differential injections. And what I've found through the years is human anatomy is very variable. And it's always quite surprising to see what you think was one thing is another, and you can confirm for sure under ultrasound guidance. So ultrasound shows the soft tissue interfaces between the different densities or impedance, and there's a sound wave reflection that produces an echo. And that sound wave is perpendicular to the surface of an object being imaged, and that will be reflected more than if it's not perpendicular, it may bounce off. So additionally, sound waves can be absorbed depending on the density or refracted, meaning that it bounces off at odd angle. So absorption of the sound wave is enhanced with increasing the frequency of the transducer, as well as the tissue viscosity will help increase the absorption of the sound wave. So when we talk about ultrasound frequency, the transducers are designated by the range of sound wave frequencies it produces, and that's described in megahertz. So the higher the frequency, the higher the resolution or clarity or granularity of the image, but that is at the expense of the sound beam penetration due to the sound wave absorption. And so the higher the frequency, the more clear you can see it, but the depth is not going to be as accessible. With the low frequency transducers, you are able to assess those deeper structures, but at the expense of resolution. You have a lower resolution picture. So these are our probes. We have a linear probe in the 12 megahertz, a curvilinear probe at the 9 megahertz, and then a compact linear used for very small structures that you don't need depth at the 15 megahertz. So it'll improve the quality of the picture. So we talk about transducer movement when we're talking about how to best get the picture, and when I'm coaching people what hand motion to use to get that picture to really be sharp and clear. So we have that heel-toe maneuver, as well as the toggle maneuver. Sometimes you call it the wig-wag maneuver if you're the dog wagging the tail. And then I really always think about this ultrasound probe as like a flashlight. So this is a transducer beam orientation. So basically the linear probe is pushing sound waves out, and you can see in a clear path directly beneath the transducer, just like a flashlight. And just like a flashlight, you shine, quote, shine the waves or the beam to the location that you're trying to see underneath the transducer beam. Additionally, on the side of the screen, you're going to be able to see markings showing depth of measurement, and you can adjust the depth with the buttons. But this is a picture of a posterior aspect of a shoulder, and you can see that the transducer, this is a linear transducer, and the beam is showing directly posterior. And you see the glenohumeral joint with the H being humerus, G being glenoid, and the rotator cuff overlying that as well. With skin being at the top of the square right here, and then the loose aurelian tissue, deltoid, tendon, muscle of the rotator cuff tendon, humerus, glenoid, and labrum. And so ultimately, I always try to remember the depth. Especially if you're looking at doing an injection or something to that, make sure that you have a long enough needle to get to the target that you're shooting for. So when we're talking about transducer alignment with the needle, we speak about whether it's in plane, meaning collinear with the probe, or out of plane, which is perpendicular to the beam. So if the beam is coming down this way, then the needle is perpendicular, whereas if the beam is coming this way and it's in plane, that's collinear. So this is how we talk about when we're describing a technique of injection. So if we're doing a glenohumeral injection, in plane technique, linear probe, and in long axis of the structure that we're aiming at versus short axis, and we'll go over that. So the transducer alignment on tissue, so this is a carpal tunnel, and these are the nerve and tendon, and this is in long axis, so along the beam plane. And then when we turn the probe 90 degrees, we are then in short axis or cross section of these linear structures. And so we talk about, are we in the transducer alignment on the tissue? Is it long axis in plane technique, or is it short axis in plane or out of plane technique? So these are variables that we talk about when we're talking about injection-based therapies. Additionally, we talk about image appearance. So we have a hyperechoic, which is a large difference between the impedance. So this beam is strongly reflected and you have a very bright echo. And it's just going to be this bright white line. Usually that's how bone appears. Hypoechoic, a very weak or low echo signal, like fluid. And then an anechoic, meaning it's completely black, meaning that there's shadowing posterior because no echoes are extending beyond the interface. So when you see this bright white, that's bone, and black shadow behind it, that's anechoic. And then isoechoic is equal echogenicity to these adjacent soft tissues, just as in the other picture. So we'll go through tissues, and what we'll say is, we'll explain it, the echo texture as well as the echogenicity. So this is normal tendon behind, along the arrows. This is actually patellar tendon. And this is a hyperechoic, meaning a little bit brighter white, with a fibular echo texture. So there's densely packed fibers, and this is contiguous. So tendon goes from bone to muscle. We call the patellar tendon a tendon, but indeed it goes from bone to bone. So maybe calling it a patellar ligament may be more proper, but that's neither here nor there. And this is imaged, most tendons are best imaged on long axis. And you really are able to see distal, if you're an ultrasonographer, distal is to the right and proximal is to the left through here. And so this is patella, this is tibia. And so that's just a way that ultrasonographers or angle injection-based therapy physicians sometimes orient the patient differently. This is normal muscle. So this is hypoechoic. So that tissue is separated by a hyperechoic fibroadipose septae and perimysium that surrounds those hyperechoic muscle bundles. And then you see down below, you're going to have that acoustic shadowing with maybe some posterior reverberation because it's nice and smooth and flat. But you can see these are the striations, just like normal muscle. And then you can see these hyperechoic perimysium or the fibroadipose septae. So that's normal muscle appearance. And these are just pattern recognition, and you'll get used to seeing these. So next is cartilage. There's two types of cartilage. There's the hyaline cartilage, which is hypoechoic, and then the fibrocartilage, like the labrum, which is hyperechoic. So this is a shoulder, and this is the humerus, and the overlying is that dark stripe and that's the hyaline cartilage. It's hypoechoic, and then this is the labrum, and that's that fibrocartilage, and it's hyperechoic. And then if you look, you can also see the dermis and the epidermis, and then hypoechoic septae down below, or musculature as well in cross section, so not in long axis. This is ligament, so bone-to-bone connection. This is femur and tibia. This is an MCL, and it looks similar to tendon, and it is hyperechoic, but it's a little bit more compact than the tendons, as you would expect. And you can always make sure that you have this compact linear hyperechoic structure from bone-to-bone connection is ligament. Next is nerve. So nerve fascicles are hyperechoic, and then you have hyperechoic fat surrounding them, and it displays in a honeycomb or speckled appearance because of the mixture in the hyper and hypoechoic relative to each other. And so when we take a look at this next view, we see that this is median nerve in short axis or in cross section, and this is median nerve in long axis. And so you can see this beautiful honeycombing. Next to it is a tendon, but this honeycombing, hypo and hyperechoic texture is a honeycomb appearance, and that's the median nerve. And those nerves will appear different from the fibular texture of the tendons or ligaments, but on long axis view, it is sometimes quite difficult to identify the difference. So we have this thing in ultrasound, it's called anisotropy, and it's a variation of echogenicity, very particularly in tendons, because we have to image the tendon perpendicular to the ultrasound bone, and it appears as a hyperechoic fibular appearance. However, when the beam is even angled as little as 5 degrees from the long axis, the structure can appear abnormal. And it's unclear if it's actually an injury or if it's just anisotropy. And this is where the variation of the ultrasound interaction with the fibrillar tissues is called anisotropy. And it does also happen to tendons and ligaments, but and in lesser extent muscle, but more specifically is tendon. And so it's really, really important to mitigate anisotropy by making sure that you are perpendicular to the area that you are imaging. So this is an example of a rotator cuff with anisotropy here. And really, we worry that maybe this is a tear, but it's just because you're not perpendicular as the fibers come down and insert. Your beam is not perpendicular to the long axis. And so it's not showing the true form. When we move our probe just a little bit over and we're now perpendicular to the structure, that clears up. And so that's one way to make sure that you don't have an actual tear and you're just looking at anisotropy, is to make sure that you're in perpendicular to the sound beam and it's reflecting back to us. So I want to go over a little bit about how to hold the probe. So this is ultrasound probe technique. And so obviously any probe has a nice orientation marker, and that orientation marker is on one side or the other, and that will on the screen indicate a blue mark or a blue dot so that you can always know when you're holding the probe and you know which side the marker is on, you'll also know which side the orientation marker is on the screen. So just be familiar and start memorizing that and remembering where that orientation marker is on the probe. Now, ultrasonographers are pretty particular about these orientation markers on the screen, and they have some recommendations to always keep it one way or the other. Some injection-based physicians are variable and place the anatomic structure oriented as the patient is when they're looking at them to help with needle guidance and needle craft. So that is going to be up to you depending on what you do for ultrasound use. Next, we're going to recommend this tripod technique where those three, the small ring and middle finger, are going to be bracing on the patient, and you're going to be holding the probe between the index and thumb. Sometimes, depending on the size of the probe or the size of the hand, you may want to use 3 fingers on the probe and 2 fingers in the tripod position, but really always have the fingers on the patient bracing, and because you're not going to be looking at the probe, you're going to be looking at your screen. And so you don't want inadvertent drifting or sliding, especially with the ultrasound gel. And this is one way to avoid that. And then you're going to be still bracing with those fingers as you turn long axis and short axis, taking care to pinch more like a pencil the ultrasound probe and have really good fine control over minuscule movements, both in toggle and heel toe, as well as translation and rotation. So what we don't want is we don't want you to be holding it by the end of the probe without bracing on the patient, because that gives a lot of room for error and drift, as well as not good control of the probe as you're looking at the screen. This is another alternative, like you saw, the 2-finger technique with the 3rd finger on the probe to control fine motor. And then obviously you're still, when you're picking it up more like a pencil and controlling the top with the index finger. So that's another alternative contralateral grip with the index and middle on one side and the thumb on the other to really get good control. You're still using the small and ring finger for bracing on the patient to make sure that you're not sliding or translating inadvertently. So these are our ultrasound textbook references. Please, if you're wanting more guidelines, the AIUM guidelines is a great guideline. The ESSR is also a great guideline to be able to go ahead and look online, and they can kind of run through all of that ultrasound examination. And then don't forget, if you want more about the business of orthobiologics, I have a podcast, or you can go on my website, The Business of Orthobiologics, and tune in. Otherwise, thanks so much. We'll see you next time.